Our last session of the day will highlight another effective way of addressing trauma. I'd like to welcome Elaine Miller-Karras from the Trauma Resource Institute and Linda Grabby from the Woodruff School of Nursing at Emory University. And they are here to talk about what's called the Community Resiliency Model, which addresses trauma using a skills-based approach to help support communities and create resiliency in populations around the world. Elaine, Linda, over to you.
Thank you so much, Scott, for having us. Lindy and I are going to be sharing the presentation. I'm going to go first, and we'll be going in and out with giving a little appetizer of the skills and talking about our concepts. And I wanted to start out by saying that so many important issues have been spoken about today. And one of the things that we have seen with the community resiliency model is the accessibility, because we talk about the nervous system, and we all have a nervous system, whether we live in Pakistan, where I live in California, where Lindy lives in Atlanta, and the many different places I've been across the globe. And it has been that common humanity that we can speak to, that and when we bring skills of well-being that can be easily accessed, that I've seen where it can help to mitigate some of the challenges that we've been talking about today. And Lindy and I will illuminate that. We call the community resiliency model not only a trauma-informed, but it's resiliency informed and focused. And when we do workshops, and we can offer these methods, these skills in large groups or individually, but we often start with these questions. What or who uplifts you? What or who gives you strength? What or who helps you get through hard times? Kind of what else may be true in your life in terms of also the suffering that you may experience. And of course, we acknowledge, but we also want to lean into these other very important factors that some people call how we cultivate our resiliency. And I remember being in the Philippines after Typhoon Hunan, and one of the ladies that we were bringing these skills to said, "Oh, thank you for reminding me what I already knew but had forgotten." So the skills that we have are very simple, and they help us calm ourselves and to regulate our nervous system. That leads to us having clearer thinking and being able to, we say, do the tasks of daily living in a way that contributes to ourself, our family, and our community. But there are many definitions of resiliency. And since we've been talking a lot about children, I wanted to bring in someone who I greatly admire, Dr. Christina Bethel from Johns Hopkins. And she has worked a lot with how do we mitigate the impact of the adverse childhood experiences that Dr. Khan so expertly shared with us earlier in the day. But her definition of resilience is very simple: staying calm and in control when faced with a challenge. And when children could do that, it actually reduced the negative impact of adverse childhood experiences. But we all know that many children and many adults, we might try to stay calm when we're faced with a challenge, but it can be difficult. So in the community resiliency model, we have 6 very simple skills. And we also have a free app that I have the little demonstration of it there on the side. It's translated so far. It's free. It's in English, in Spanish. And we just recently are getting it translated into Ukrainian for a Ukraine project that we've been doing. But what does the community resiliency do, and how did it kind of come to be? It emerged after not only disaster response, but also primary care. I was a teacher of family medicine at Arrowhead Regional Medical Center, a large county hospital in California. And one of the things that was very clear to me as I co-attended with the medical faculty, and I was a behavioral scientist, when people were coming in with many complaints, my stomach hurts, my head hurts, often the base of it was trauma, just like Dr. Khan illustrated in his presentation. And we didn't really have a way to talk about that because we were looking for kind of the real medicine. And so when we started integrating the idea of neuroscience and how trauma affects the mind and body, we started seeing changes. So with the community resiliency model, I felt that there needed to be something that was more accessible, that was easy to use in multiple settings. The other thing, I've had the great advantage of being invited to go to many places after disasters in the world. I've been to Nepal, I've been to Haiti, I've been to many places in the US. And I've seen where when you bring in a model that, again, has to do with the nervous system, And there's so much commonality in how we respond to things that it brings people with that idea, oh, so what happened to me is about the biology of the human nervous system. I rarely use the word trauma, although I do use the word trauma. But then it makes the opening, that doorway to get help, to learn skills of well-being more accessible to people. We have seen, as I said, we've used this across cultures and also across the lifespan. I often talk about my 105-year-old father-in-law that died in 2019, and he was able to learn the skills. So we can also teach this to young children. We have many stories of young children teaching other young children the skills to help them when they get knocked out of their resilient zone. And this is one of the key concepts. We also call it the OK zone, the zone of well-being, in Spanish, la zona de bienestar. And this is a very simple concept in that we all have this rhythm that exists within us. And it's not a flat line. It's not just the Zen zone or the calm zone. It actually has, it has all the components of really the emotions of human beings. So we can actually be okay sad and okay mad, but we're still within that zone, and we can still manage our thinking and say, well, you know, I'm very angry that this happened to me, or I'm sad that this my family member passed, but I can handle the emotions that are happening as a result of this. And part of what we do is, when we talk about the resilient zone, is we also want to integrate very simple neuroscience information. So we help people understand the accelerator and the brake of their nervous system. So we talk about the sympathetic and the parasympathetic. And at times of distress, right, then that our foot can be on the pedal of our nervous system, or our heart is beating fast. We may have tight muscles, but there's ways that we can put the brake on. Some people may not even know they have a brake, where we've experienced that deeper breath, our muscles relax, and we have a greater state of well-being. So one of the key components of this model is helping people tell the difference between sensations of distress and well-being. Because as we all know, we all experience distress. So here's our resilient zone, but the Thunderbolt can be reminders, like the cues that that Benjamin talked about earlier, that can knock us out of what we call our resilient zone, and it can land us in what we call the high zone. And when we're in the high zone, we could be edgy, irritable. Oh my gosh, we can say things that we regret and have to apologize for later. Or we can get bumped in the low zone, where we feel disconnected, depressed. We don't want to get out of bed. And I've asked this question all over the world. How many of us besides me have been in the high zone? How many have been in the low zone besides me? And I always get everyone's raising their hands. So we kind of distill the complexity of how we talk, let's say, about trauma, in this way of talking about these zones that people can relate to, whether you're a little person or you're an adult all over the world. And we also talk about common reactions. So here I am, an old trauma therapist, so I've been very versed in the DSM-5 and the ICD codes. But when I'm talking to regular folks, I say, well, how has this stressful and or traumatic event affected your thinking, your physicality, your spirituality, your emotions, your relationships, your behaviors? And if you look at this slide, I'm not going to read everything in it, but these are common all over the world. To me, it's been so amazing to see the commonalities of that. And when I say that, I recently said this to a group in Haiti, they go, you mean people in the United States experience the same thing? I said, yes. So again, it brings us together, but it's also a way of helping people understand that these events impact every aspect of life. So it's not only psychological, but it affects our thinking. And of course, the physical I put in the middle, because many people go to primary care providers, like in my experience of being a teacher of family medicine, because these are driving them to the doctor when it really has to do with trauma. So in the community resiliency model, we talk about biology versus mental weakness. So we talk about the biology of the human nervous system. We talk about the human reactions that we just discussed. And then we talk about how we can start to read our nervous system to tell those differences between sensations of well-being and distress, because when we can, we have a choice of what we want to cultivate inside of ourselves. So Lindy, over to you.
Thank you. I just want to mention that dysregulated image of the resilient zone is quite comforting to people. And I think it destigmatizes, it normalizes stress reactions. So it's very comforting. People see that and have a sense of relief. The first skill is tracking, which is simply noticing sensations in the body in the current moment. So we all do that naturally. We can tell if we're too hot or too cold, right? Or if we're hungry or need to sleep. So our body is set up naturally to do that, but it's usually signaling discomfort, perhaps. But what CRIM does is tap into neutral or pleasant sensations and lean into them. So if, for example, you're feeling a little bit of anxiety, localize it. Where is it? Where are you feeling that in your body? And maybe characterize it. And then, is it pleasant, unpleasant, or neutral? Probably unpleasant. So then you can use a CRIM skill to alleviate it, possibly. But leaning into sensations that are pleasant. Next slide. We have this research that was done in Finland, and this has been done on 4,000 people in 100 countries, where subjects have documented where they felt activation or deactivation in their bodies when they were looking at images, for example, or text that would evoke these emotions. So the yellow and the red are activation or energy. So you can see with happiness and love, there's this sort of suffused activation, pride as well, but anger too. And take a look at the fight and flight in the fists and the feet too of anger. So very often when we're having a strong emotion, we don't have access to the higher brain functions, but CRIM is a way to pull that on board. The blue represents deactivation. So you can see that leaden limbs with depression and sadness. Next slide. We probably have those sensations before we even know we're having those emotions. Where does interoception happen? That's that awareness of internal sensations. Well, the hub is the insula, which receives messages from the body through the brainstem, and then is cortical tissue and is connected to the prefrontal cortex for our good decision making. When we do go to the trouble of tracking sensations, noticing them, simply, I can do it right now by noticing the texture of my skin. This is interoception. This is a kind of self-care, actually. We're practicing CRIM there. But the insula turns out to be the hub also for all of these wonderful other things: emotion regulation, empathy, social interaction, and sense of self. And how can't you argue with the fact that sensing into your own body is kind of the most fundamental way to sense who you are. Next. In CRIM, we teach people to start using sensation words. And so it is a kind of mindfulness, but it's purely sensory. So it's kind of almost like a high octane mindfulness. Start thinking about sensations in the body. Certainly pain and temperature, we're very aware of, but we can also notice if our muscles are tight or loose. We might sense vibrations. And so, of course, we can make up words to describe sensations. And by the way, children are experts at that. So by naming emotions and naming sensations, localizing them, and then maybe characterizing them, we can really do some amazing things. I've been teaching this with high-risk kids who are either incarcerated or in homeless shelters. And they're so responsive because they have a sense of control that they didn't have before. Elaine?
Thank you. I want to also just tell a brief story. I was in India in 2019, and I was interviewing a group of children who lived in Dharamsala, and they most of them had grown up in the slums of Dharamsala, and the children were all in the schools, and they were so excited to be presenting at this conference. And so the question I asked them is that, well, can you tell me what you like best about about the skills of CRIM, for example? And so one little boy raised his hand, and he was so sweet, and he talked about that one of his parents had died, and the other one was a drug addict, and his two brothers still lived in the slum, and he was lucky enough to be selected for the school. It's called the Tonglen School in Dharamsala. And he was talking about this exact thing about sensations. And he said, well, what I learned that was most important is sometimes I feel so sad and depressed thinking about what's happened to my family, and I don't get to see my brothers now. And I feel this heaviness in my arms, but now I know I can do one of the skills. And when I do one of the skills, I can slowly feel the sadness start to drip out of my arms and out. And then I feel less sad. And I love that he said less sad, because then I could go back to study and learn again. So that was such a profound moment for me when he said that, because I thought, gosh, if this little boy can learn this now, and he was about 10 years old, how he can use this through his life that could possibly mitigate some of the adverse childhood experiences that he has experienced, but how also could that affect what may be later mental health conditions that he might actually be intervening on his nervous system right now to create this greater sense of well-being. And that brings me to the next skill. The very best way I've learned around the world to read the nervous system and to teach people is by a resource. And a resource can be anything. It can be a person, place, a thing, a spiritual belief, something that uplifts you, that brings you peace, calm, that makes you feel strength and resilience. It can be real or imagined. Some people say, well, I don't really have a resource. And I said, well, can you imagine one? And it also can be internal or external. So some people might say, well, I don't know if I can think of an external one, but I think I am a compassionate person. So I might ask them, well, can you tell me about that compassion? And as we help people with identifying resources, and I really would like to take even a minute or so right now, even though we don't have a long time, for you to think about one of your resources. What gives you peace or calm? And notice all the images on this slide. It really is about the resource intensification. You know, are there smells, are there touches, tastes, sounds connected to that resource? And as you expand the thinking of it, I'm going to invite you to notice what happens on the inside. And for many of us, and I'm thinking about my granddaughter who's 6, who lives in my house with my daughter and son-in-law, I just automatically, I sit up a little bit and I can feel this kind of warmth come over my body. And I don't know, Lindy, if you noticed, I took a deeper breath. So I can sense that well-being by calling up the image of her and experiencing that. So it's really important to know that we can drop these resources quite simply and kind of stay with the resource for 10 to 15 seconds, research has found, in order to fully sense that kind of resource inside of ourselves. So this becomes just such an important part of who we are. So conversational resourcing is another part of what we do. And this has been very important. Right now, we're doing a project in Ukraine, and we've been doing it on Zoom. I've been meeting with Ukrainian through EdCamp Ukraine. It's an association of about 35,000 teachers. So some of the questions that we ask as people bring up different aspects that they may be experiencing is, can you tell me the moment that you knew you had survived? Can you tell me the moment that help arrived? What or who is helping you the most right now? The questions that have come to us have been poignant, tragic, sad, but we're dealing with it in present time. And we can do that by these kinds of questions that help people start to think about the other things that may be true, even in the times of great distress. And I have to say that I have been absolutely humbled by what people have shared with us. So there's many questions here that we ask after loss as well, but I want to kind of go forward because I want Lindy to be able to talk a little bit about our research with the time that we have left. So Lindy?
Yeah, we've been doing research for a few years now. This was our most recent RCT RCT of a 1-hour virtual CRIM class during our first surge of COVID here in Georgia. And we were looking at the WHO for well-being and the secondary traumatic stress scale. And we had some strong results in the intervention group. But also it was perception of teamwork. So there's something that goes on when you practice CRIM, this body awareness, you have a different perception of yourself and the world. Next slide. The other research we've done was with nurses. That was the first RCT of CRIM here at Emory. And also the next one was quasi-experimental, but again, we get the same results, significant improvement. But my dearest clientele is really women with addiction. And so they were incredibly responsive to CRIM. It's something you can teach even in one sitting. And then next slide, please. There's research that was done in Rwanda with Tutsi genocide survivors. So this is decades ago now. But what they found in the intervention group, this is Sam Habimana, was a significant decline in depressive symptoms, stress symptoms, and trauma-related symptoms. So there's something that really does seem to help people here. And I hope you'll be very, very intrigued. And by the way, there is a psychotherapy level of this called the trauma resiliency model. So I hope you take a look at that. Now think about the health impact pyramid. CRIM is absolutely right smack dab in the middle here of a long-lasting protective intervention. We're operating up here a lot of the time. This is psychotherapy and prescription of psychotropic medications. This is one-to-one, highly labor-intensive and expensive. If we can move down the pyramid to making interventions at broadest level. So 550 people were on this call today. Perhaps some of you will start tracking your internal sensations. Elaine, go.
So I'm just going to, end with this slide, and I'll also show you how you can get in contact with us. But it actually can be scaled quite easily, because one teacher, and I don't know, Lindy, how many people have you trained so far? It's been in the thousands.
It was 6,000, but that was 6, a couple of years ago.
So scalability of it is, and also we teach natural leaders of communities to be community resiliency model teachers. And I think that's been one of the deepest learnings for us. If we are really going to truly touch the amount of trauma and mental health challenges in the world, we just don't have enough mental health therapists. But there are plenty of natural leaders who are already the go-to persons in their communities. And if we give them additional skills that are based on neuroscience that helps to stabilize the nervous system, I think anything is possible, and we can actually change not only ourselves, families, and communities. And if you have questions for Lindy or myself, we're glad to answer any question, and we'll stop there for questions.
Thank you very, very much for that overview. That was fantastic. A couple questions here. So I mean, you actually just touched on it right at the end. It seems like this is a model that can effectively be taught to lay health workers, or even usually saying members of the community that aren't even health workers. Would you be able to speak to, how much time would be needed to effectively teach us so people would be able to take it to their own communities and go from there?
Yeah, so the way that we have it set up right now is we have a 40-hour teacher training. And after those 40 hours of teaching, people become provisionally certified as CRIM teachers. And then there's some additional consultations that we ask people to participate in, a take-home assessment that they write. So we make sure that they know the ingredients of it. But really, after the 40 hours, we encourage people on day 6 to start teaching. Right now, we're doing a teacher training for Ukrainian educators and other administrators throughout Ukraine. And we're doing it in 4-hour segments because of the time difference between California and Ukraine. So we're doing it over 8 sessions. So we're trying to make it really user-friendly for those folks because they're going through so much right now in Ukraine.
But I want to add that you yourselves can consider yourself CRIM guides. If you listen to the app, then you can turn around and teach it to your kids or your partner this evening.
We would like to have an army of CRIM guides all over the world, because once you learn the skills, and I think this is what we see in the research, people continue to use the skills for themselves. And that really does promote their well-being. And we see that when there's been the research that's been looking at people a year after they've learned the skills.
Excellent. You mentioned that CRIM has been implemented with children. You're speaking to your experiences before in India. Would you speak more to that? Exactly what that looks like?
Well, we have an association with the Sea Learning program at Emory University. It was inspired by His Holiness the Dalai Lama. And so the Sea Learning is completely free. I mean, anyone who's listening can go and go to their website and become a facilitator. So we're chapter 2 of the Sea Learning program that's now being implemented, I think, in over 17 countries around the world. And so that's one of the ways that we're integrating it in schools is through Sea Learning. But the other thing that's happening within our organization is that many school districts are coming to us saying, we want to not crimize our school. So we have schools in North Carolina, we have schools in Belfast, we have schools in California, different parts of the country that are integrating the CRIM skills, not only for the kids, and this is something that we really believe in our bones, is that it needs to not only be for the kids, but for the teachers and for the parents, for the people that work at the front desk, for the janitors, for the people that work in the kitchen. If we become a community that has a common language, that are working on these skills of well-being, then we have seen where it transforms communities, families, and individuals.
That's great. So one more question right at the end. Again, you mentioned the trauma resiliency model. Would you speak to the differences between that and the community resiliency model?
Yes, so the trauma resiliency model is directed towards mental health professionals. So it not only includes learning the 6 skills of the community resiliency model, but it includes other skills, 3 other skills that help to reprocess the traumatic experience. You know, one of the things that we feel is really important is people are going through and, let's say, remembering one of the worst days or the events of their life, that they have like a safety jacket on that has skills where they can regulate their nervous system. So they never leave like the trauma resiliency model session out of their zone, that they have skills that they're able to regulate, to come into their zone, to maybe think about the processes that they've gone through in therapy. But these wellness skills we feel are important. And there's one other thing I want to say about the trauma resiliency model and CRIM. And this can be blasphemous for some of you to hear, but we have learned that not every person, not only do they want to talk about their trauma, but that they don't need to talk about their trauma. And that we can work with the implicit memory that Benjamin talked about. Because there are some people that have had things happen to them that have been traumatizing before they have declaratory memory, but it's still held in the body, because that develops intrauterine. And people can just say, well, I don't know what's going on with me, but I feel these sensations every time I see blah, blah, blah. And I go, well, we can start there. So what are you noticing on the inside? And we can help them learn how to release those sensations in their body so that they can feel more whole in mind, body, and spirit through the trauma resiliency model 9 skills, or through the community resiliency model skills. And that's the other thing we've learned. People say, well, I don't know if I really need to reprocess the trauma. I feel like I can manage my life with learning how to intervene on those cues that have happened to me my entire life, because my body's been talking to me my whole life. I never had skills where I could talk back to my body. That's so important.
Very good. One last question for you. When it comes to CRIM, is it, I don't want to say is it more effective, but is it just as effective when it's implemented with a group as it is if it was done with an individual?
Well, Linda, you want to talk about that? Because I think it is, but I think your research is showing that. Do you want to address that?
You do not need to do this one-on-one, although if you want to act as a CRIM guide, you need to do it one-on-one. To get these beautiful slides from the Trauma Resource Institute, you need to be trained and certified as a CRIM teacher. This absolutely works in groups. We have weekly classes at the homeless shelter for teens here in Atlanta. And we always talk about the resiliency zone. They generally want to grab the placard and teach it themselves, actually. This is amazing. 4 of those youth have trained as teachers. But then we'll dig deep into one of the skills. which could be, help now is something that we use kind of when we're really dysregulated to get back into our zone. And they can help each other. There's something about altruistic that comes out in the kids when we teach them. So we pair them up and they use one of the skills to help out their partner. It's very sweet.
And I just add to that too, we're not certain, and we'd certainly love to get more research on why this happens, but when people tend to access that resilient zone and experience that parasympathetic part of their nervous system, they not only have more self-compassion towards themselves that happens just spontaneously, but they also have more compassion towards people in their community. And we've even had people, this has come out of the genocide work in Rwanda, where they can look at the people that were responsible for the genocide and have compassion towards them. So, for us, when we see this happening, we want more information about why it's happening. That's why we have like a very robust a research committee within our organization, about 100 members from different academic institutions. But we want to know why that is, but also the implications of if we can bring this and scale it to even more people, how that could help people digest that trauma that gets stuck in their nervous system, to release it, to show up as their best selves.
And there are plenty of people who have had high ACE scores, but who do well. And it's because they have the impact on their brain, but they have compensatory pathways that they may have gained as children if they had a trusting adult, for example. But we may be able to offer some somatic skills to them to counteract the trauma that they've had early on in life.
Thank you both so much for being with us today. I hope you're going to stick around for the Q&A, which is coming up right now.